Good, and you?
We're good. It's 4 p.m. here,
Hmm.
so I think we shall start. So, I welcome all the participants to this third Stereotactic Radiotherapy Learning Module session. This module we began a few months ago, and of that series, today we will be discussing a role of stereotactic radiotherapy in renal cell carcinomas. Today we have with us our speaker, Dr. Thomas D'Souza, who is a radiation oncologist at Glen, the McGill University Hospital in Montreal, Canada. He was trained from the leading South American faculty at the Teaching and Research Institute of the Syrio-Lebanese Hospital in Brazil. He is a member of the NRG Oncology Genitourinary Committee and was recently honored with the most prestigious Mitchell McTay Young Investigator Award in the year 2025, recognizing his contributions to advancing cancer care and clinical care. Dr. D'Souza completed his genitourinary radiation oncology fellowship at the McGill University, an institution which is renowned for its pioneering work in LINAC-based SRS, a legacy led by the figures such as Dr. Louis Suhami. Currently,
Mhm.
Dr. D'Souza is further refining his expertise through a dedicated SBRT fellowship under the mentorship of Dr. Neil Kopeg. So I would like to welcome Dr. D'Souza. The floor is open for you.
Thank you so much for that. It's my pleasure, and I'm really honored for this invitation. And with my colleagues Munib and Hamad, we learned a lot together, and it will be a huge pleasure to share a bit of our learning, because it's still a matter of learning, and will be a pleasure to discuss. And please feel free to interrupt me in any time for questions, for discussions. Uh, I think that's the whole point here is to be getting together and learning and discussing and sharing our experiences. We have a lot to learn and discover in this new field. Can you see my screen?
Yes, Dr. D'Souza.
It's showing my PowerPoint, right? So I think so. So uh, thanks for that. And talking about kidney cancer, we know that the prevalence and the incidence are increasing, and now kidney cancer is the seventh with more prevalence, according to the SEER analysis in 2022. And this is something related. We have to understand better, because there's like a progression. Maybe when we see curves on epidemiology since COVID mostly, and also with the access of CT scans because of many other reasons. So we have a lot of incident findings, but the data is that is the seventh more incident tumor, but we have a progressive increase in on diagnosis mostly because of incidental findings. And this was interesting because we start thinking different. Maybe we like pandemic, war. These things used to make us to find new solutions and to think about new things to solve new problems. So since we got with with the increasing of the incidence of renal cancer because of more CT scans or not. So how we're going to proceed with this since as we can see here, most of our patients, they are, look, or the incidence here, it's if you take in consideration the prevalence over 65 years old, so we're talking about 50, almost 70% of the case we are going to see, they are patients over 65 years old. So, and it's much different when we see a patient on clinic with prostate cancer with 70 years old or a renal cell carcinoma because most of renal status and comorbidities. So we have to think about this approach since the standard treatment is nephrectomy. So, but since we're dealing with a population that 70% of the case we are going to meet they will be over 70 years old and probably with some renal disease already. And so I think here we are most radonc, right? I don't know if they're medonc or urologists, but okay, we're talking about kidney cancer in a Sunday afternoon in Pakistan, in a Sunday morning here in Canada. But what about radiation? Because at least in my training, I don't know in your training, but in my training, I saw few cases. I think I remember of two cases of kidney cancer, and we treated palliative, one palliative, and one post-op with a very strange situation, a very particular case. And when we go and like I was saying on training, so. I remove it here, but I was joking about this some days with a discussion with the trainees. And if you open Paris, so let like open. I told them open Paris now, and see. Tell me because I said I asked them about the indications and our role in on kidney cancer, and I said so open Paris now, the textbook and tell me. And I called vintage because we don't see this on real life. So, like, try to remember the last time that you offer or you treated a renal cell carcinoma with adjuvant radiotherapy, and this is what we have on our textbooks nowadays. And or when have you done preoperative radiation for kidney cancer? And then what remains in the end when we have like the resident was asking about a question on the exam that they had, and by the book by Paris is the exclusive radiations basic for palliative. And this is supported by our textbooks, not even textbooks from urology or from Medonc or whatever, because we define a renal cell carcinoma or a kidney cancer, and mostly renal cell carcinoma, as a radio-resistant tumor. And I remember that my mentor back in Brazil, once he told me, Thomas, it's not difficult at all treating cancer, put the cancer, put in the table of the LINAC of machine radiation and deliver 100 grays. I don't think nothing will remain there. But the issue and the magic and the beauty is to treat the cancer and the patient like holistically. So that's seems obviously, but when we see this case, it's not that much. And some very interesting news, and we are living like a very nice moment on radiotherapy. Like last year, Astro in Washington was amazing because the open session, the main session, started with I think it was kidney before, yeah. It started with Shankar Siva, with amazing presentation talking about the moment we're living, that we're breaking paradigms now, and we as Radonc we have to be on this board, not because okay we are Radonc, okay let's take the flag of radiation for everyone. No, it's because of the patient. So this is a pretty good news because at least there's the citation of radiation here. So the new NCC from 2025 says that for stage one kidney cancer, primary stage one less than 4 centimeters, the standard treatment is partial nephrectomy. Finally, after 2011, was defined as guideline for mostly because of renal preservation. For to be a nephron preservation, nephron sparing should be something prioritized, since we are dealing with patients that mostly are not going to die because of disease, but maybe some because of some kidney failure that we may cause as physicians. And in case of a partial nephrectomy cannot be offered, and this is very common since comorbidities or the patient just refuse, ablative techniques are recommended. So uh, and for T1B, so we divide, so for T1B also, same thing. But when they say ablative technique, they prioritize it's for percutaneous ablation or RFA, radio frequency, or cryo. And after them, we are the backup. But this is, I just can't get it. It's difficult to understand exactly where did it come from. Just because they started before us, because we have a few literature regarding kidney saver. So we don't have randomized trials, and we just have we have like a pool analysis, like the IROC, and now the fast track. That's a small phase 2 trial and single arm. But when we see percutaneous ablation, they have much less evidence than us. They have few series and they are not like standards with there's no standard basically. And also there was a recent publication 2 months ago on Lancet that they compared they did a pooled analysis comparing percutaneous ablation, specifically radiofrequency RFA, cryoablation and SABR. And first, that method, that review, that study, that publication on Lancet from 1 month ago, showed that we have more literature, even though our based on retrospective data, and we do better since on cost analysis, and since because we are able to treat as a non-invasive treatment with very few profiles of toxicity. So uh, at least now we can say, okay, we are as a 2B category, we can offer saber to kidney cancer. But when we talk about what if patient is not a candidate for partial or nephrectomy, he's not a surgical candidate, and he has a lesion bigger than 4 centimeters, which the most probably you are going to find. So we are the only one option since percutaneous ablation doesn't they don't have good results after 3 4 centimeters in reason of the leaving or the thermal ablation in more than 3 centimeters because it's difficult technically for obvious reasons. And that's the issue. When we say, okay, what's the problem of radiation? Open Paris and see, it's because it's it's a resistant tumor. Is this like true? Is this like just some gossip, or is just something that we believed and we accept? So probably because like talking with people and with mentors and with our community of prodonc and oncologists, in the past, because of the technology available at the moment, we and also with different concepts, uh, if when we try to deliver high dose, we cause a lot of toxicity. So imagine on with 2D and on the very beginning of 3D planning, there was some indications and using full dose for kidney cancer, likely 65 to 70 grays. And there was many reports of high toxicities. My mentor in Brazil, he told me that once he treated back to 90s and uh, didn't work well due to many ball toxicities, flank pain, and also not a good response. So then there was the myth of RCC being a radio-resistant tumor. And in fact, it is. So we have many models showing likely melanoma or likely many other tumors. But when we for example, even for I used to do this joke like because on Hiroshima they say that after the atomic bomb everyone we know what happened, but someone stayed there. So some the insects, they are also radio resistant, or we just don't deliver the enough dose, the dose able to do what we want to. So when we see like when radiation is used for cleaning things, for cleaning, we have those that and we know for insects, for mollusks, so and for reptiles and etc. And we can see here it's kind of interesting. Likely, okay, it's sensitive. We know that with those of three grays in human being, we have effect on DNA. But for insects, for example, like on Hiroshima, maybe we might need over 1,000 grays. So it's sometimes about that. It's about being able to deliver a ablative dose, and or at least the dose that we need. And what started changing our way to our way to think on kidney cancer in kidney cancer was like along the evolution of the techniques of radiation. We start doing SRS. And with a, so treating metastasis from renal cell carcinoma with SRS back to 1990s or 2000, beginning of 2000, on beginning of SRS with 3D, but here's things playing with VMAT and etc. But why we were able to control with 18 to 22, 24 grays in one fraction a brain met, but not the kidney primary. And also, we started doing, even with 3D in 2004, 2006, we had the experience in Brazil at McGill. They started in 2008, I think, no, 2003. SBRT for renal cell carcinoma too, since it's the most likely metastatic site. And we achieve in both of the metastatic, so in the lung, in the brain, we achieve 90, up to 95% of local control, but renal cell carcinoma is still a radio resistant, and we still see on the literature, we still see people saying and writing that it's radio resistant. So depend on the dose. If you give 10 grays for some kind of lymphoma, maybe also we should consider radio resistance. So it's about dose and what we are aiming. So in 2003, this is the first, not the first, I think it's the first report that at least with more than 30% patients, showing that the results of treating extracranial metastasis with RCC with 40 grays in 5 fractions, and was shown a control rate, a local control of 90%, 93%. So I think this is pretty awesome, and I think mostly of people will agree. And this, Daniel Fan, yes, this is a publication of the Group of Australia. So before, when they were starting there, and this is also the first, it's part of the protocol of the fast track. So when they are making to see how feasible was to deliver, so they did with 3D, not even IMRT, VMAT, nothing. So with 3D, they did a phase one trial of safeness, delivering 42 grays in 3 fractions for lesions more than 5 centimeters, and for less than centimeters, 1 fraction of 26. And among these 20 patients, they saw that was safe regarding toxicity, and this was a dosimetric trial showing that even with 3D, we're able to deliver with a good coverage and respecting the DVH. Yeah, and this is so since they saw, okay, we are able even with 3D to deliver 26 in one, or for less than 5 centimeters, or 42 grays in 3 fractions for more than 5 centimeters with a good dosimetric plan. So let's move ahead. And since then, so since 2014, became, at least in our practice, the exclusive treatment and radical treatment with SABR to renal cell carcinoma. Here, so the first report was that one that I showed. The first prospective trial was one of 7 patients in 2006. And the first patient treated at McGill was in 2011, by the way. I just found, I was reviewing the file, was in 2011. So since 2011, kidney save has been done here at McGill, mostly for, not mostly, just for no surgical patients after tumor board discussion. And now things are starting to be more, having more wide indications. And the reason that we had this difference in breaking paradigms is mostly because of data. It's evidence, and so that's the importance of not of science, but about reporting our results, reporting what we see on real life to start changing things and make patients' life better. So the IROC has a very important role on kidney saber since they are organized, basically that. So, like this was the first report from 2018 by SIVA, and here was the analysis of 223 patients in nine centers, mostly in Australia and then Germany and Japan. No, not Japan, mostly Australia and Germany, Canada too. And among 2023 patients, the median size of lesion was 4 centimeters and was found cancer-specific survival at 5 years of 91% and with a local control rate of 97.8%. And when we talk, as we said, we saw on the epidemiology, sometimes when we talk about kidney case and you want to see the overall survival, look, the overall survival here here is divided by fractionation, but it's around 60% because of comorbidities, because of the kind of patient that we are treating. And here's also shows something very interesting that's a matter of discussion, of the actually discussion because here they compared one fractionation against multi-fractionation. And we can see here that they saw difference on progression-free survival, distant metastasis-free survival, and cancer-specific survival, but local control is the same regarding the fractionation, and this was like MDT study, so like the studies looking for demonstrating still the feasibility and studying that. So on multi-fractionation, they used several schemas of those, like 2 to 8 fractions with a low dose, really like BD among 50, like using 27 3 fractions was used, 16 as palliation, 16 grays in 2 fractions was used, and also 40 grays in 5 fractions. That's the most recommended fractionated used schema. And local control was the same, but why cancer-specific survival, distant metastasis survival, progression-free survival is different, mostly because of the bias of patient selection. So as Radons, we used to see that frail lady, 90 years old, solitary kidney after previous nephrectomy doing renal cell carcinoma. And don't know, 24, 26 in one fraction. I'm afraid of something, or some back pain, of something that may happen in a 9 years old lady with only one kidney, for example. So we used to introduce this bias on fractionation, and that's the need for randomized trials, etc. And maybe the most important thing, because when you see this patient that during COVID, or the lady had she felt, and then she went to ER and did a CT scan and was seen a renal a kidney lesion of 3 centimeters. Okay, and then started the follow-up, and after 1 year the lesion grew to 3 to 4 centimeters. Okay, this indication for treatment after progressive image, or with or without biopsy, by the way, depending. And the most important thing on that scenario, it's about renal function. The last thing that you want in this lady that you just saw, who felt doing the ice here on the cold winter in Canada, and just found a kidney mass, you just don't want to mess up with her kidney function and put her on dialysis. So since we got this data, this is the first one, but we had previous one. But in 2018, this was a publication of 200 patients, and we saw that the decline of eGFR was minus 5.5. So okay. Local control seems to be amazing, but more important than everything is that we are probably not, we are not going to cause the dialysis in this lady. She might develop dialysis because of many other factors, likely the analysis of CADIGO, the renal consortium. They showed in a publication of 2008 that the patients with more than 70 years old and with hypertension and diabetes, they are likely to have a decrease on eGFR of minus 3.3 ml by minute by year. So, and they don't have renal cell carcinoma, it's just elderly patients more than 70 years old with hypertension, diabetes, which is pretty common, and they already will have a decrease on renal function of 3.3 ml by minute in a year. And a patient with renal cell carcinoma that use the patients that we treat, they are non-surgical candidates, so they used to have a Charlson score of comorbidities high, with like hypertension, diabetes used to be the minimum, plus renal cell carcinoma, and we find that we cause a decrease of eGFR of -5.5. So I think that's the big deal. That's the most important part, and that's when we are on tumor board or when we have a patient who is concerned and who is looking for treatment. Okay, I think the most important thing is that look, our data seems to be safe, and we used to decrease around 10% of renal function, and this used to stabilize. So this is a pretty important point. And Rohan did this publication that was a systematic review in 2019, the boon of starting the bump of Saber kidney. This analysis of more than 300 patients with which we can see like usually median size of 4 centimeters, because it's also are also the patients who are not feasible for, are not candidates for ablation, for percutaneous ablation. So we are the one who ate the worst players, by the way, the most elderly non-surgical candidates and with lesions bigger than 4 centimeters or close to hilum or some other place that percutaneous ablation cannot go, likely close to ureter and yeah, ureter and hilum. And we had a great result, but what I most like on this publication of Rohan Correa is that he showed and listed all the small trials that we have, mostly retrospective data. Look, the difference on fractionation. So this talk about comparing fractionation, we must be we must be aware about the background regarding that. So the comparison, look how it was done. So single fraction, of course, is easy to have a standard and a pattern, but when we talk about multi-fraction, for example, in three fraction, there was like the treatments done with 48 grays in three fractions, like top high dose, and also with 24 in three fractions. This is like a pretty palliative dose. And when we see on in five fraction, there was like many trials that used 25 in five. So these are completely different goals and those you can't like compare treating renal cell carcinoma as a radical intent with 25 in 5 or 40 comparing to 40 grays in 5. So the first data I showed, the publication of Siva of 2017 about the difference on curves, not on local control but on distant metastases, and that is mostly because of patient selection. You can see that we were in the beginning, so there's like a multi-fractionation and a big different dose. And this is something that now we are finally changing with the more indication and how more we use and how more we see kidney saver. So even with this large difference on schedule on dosage fractionation using low dose or high dose, even though there was like an excellent local control with 97% of local control and minimum severe toxicity, and this is what we see on real on daily practice. So patients used to have fatigue and sometimes discomfort, not even pain, some discomfort, and like grade 2 if you have to give some Tylenol, it's likely around 5%, and this is what was showed also shown also here, and with a very acceptable reduction in renal function, considering the population that we are dealing. So of decrease on eGFR of less than -7 mLs per minute. That's our best data. So it's the again the IROC consortium, but this is the publication of 2022 that they reported the long-term outcomes of the IROC and individual patients analysis. So on this analysis were analyzed 190 patients, 2007 to 2018, most inoperable. with a median follow-up of 5 years. So finally, we got a kind of long-term, at least, or medium-term follow-up, and very interesting. So our population that we used to do always more than 70 years old, and one third had solitary kidneys. Solitary kids due to previous nephrectomy. So this is something that I always think, when we see like patients first time discussing regarding surgery or some organ sparing treatment, we see a lot of patients with solitary kidneys, like because of genetic or more likely to have a second primary. So 30% on the publication of the long-term results of our rock had solitary kidneys. With we are going to see in all the trials and reports always tumors around 4 centimeters and mostly clear cell. Some patients without biopsy. This is also pretty common too, since patients used to have often many comorbidities and contraindications for any invasive procedure. And uh, the most used schedule was single fractions on using 22 to 26 grays, and the results were great. They found 7 year local control of local failure of 8%. So we're talking about 91% in 7 years of local control with a specific cancer survival of 92%. So this is, I think, even though it's not a prospective, randomized data, but it's a huge data showing the effectiveness and safeness of SABR in renal cell carcinoma. And the most important part, in my humble opinion, on this kind of patients is that we have few toxicity. So when we see here, where is grade 3? I don't know where it's grade 3, but it's always around 10% on the most on the higher levels, and grade 4 that really matters, very unlikely. So we had here on IROC very few grade 4. So one, two, three, four patients with severe toxicities, and the in 5 years. So remember, if the patient has like cascadic meta-analysis from the biggest group on kidney. The patients after 70s are likely to have a decrease on eGFR of around -3 a year. In 5 years, post-SABR in patients with renal cancer, in 5 years, the decrease was -14. So this it's a very fair result, very great, very good result, and what comes in my mind always when I spoke about that is, okay, but imagine our report, even if we treat like 30 patients, but top shape patients, young without comorbidities, and see probably you're going to find maybe a bigger decrease in the first year, but maybe in 5 years we'll be back to the baseline. So we have to remember that we select the patients we treat. It's very select the worst case with many comorbidities. And on among the 109 patients, 7 patients required dialysis. Remember that one third of this cohort had a single kidney. So, and something that we have to be very we have to think well when we have this decision. So in this trial, there was no difference in on toxicities between single and multi-fractionation, and this depended 100% about us, about Radon. So this is about our decision, about selecting the patient, planning, and deciding about those. So there's no difference if you respect and if you do things pretty safe. So talking about that, some technical aspects. So something that I studied that we did here at McGill regarding kidney movement. So we analyzed 50 patients with normal 4D CT using bellows. Um, And just comparing two phase, we don't even did the comparison of all the phase 100 to 0 to 100, just 50, that's the expiration and the inspiration on zero. And we found that there was no major variation on this group, and this was around 25 cc's, but it's difficult to predict. So we saw that kidney doesn't move likely lung lesions close to the diaphragm, neither as liver. That liver seems that move more. But even though we saw that some patients have a different movement, and it's not easy to predict. So we do need for sure this the minimum we need. We don't need much thing to do kidney save, but for DCT for sure we do need, because sometimes the lesion moves just it's not about this movement as we care on lung, for example, to miss the target, but it's about also going close to bowel and the target, and also the organs at risk. That matters a lot in this scenario. How this is how I rock did. So they also did with Cyberknife, with fiducials, and but this is the Cyberknife stuff is difficult because we are trying to avoid sometimes biopsy in this patient. Sometimes we cannot biopsy, and then we're going to place a big needle to place fiducials, and we already saw that we don't have benefit on using fiducials regarding here. And also they use it for DCT with free briefing. So sometimes people ask about the IBH. I'm a big fan of the IBH because because it's beautiful, and we reduce and we got better dosimetry, but we don't see a difference clinically, and the few difference on dosimetry different than lung sometimes, and without contrast, and neither abdominal compression. And what we need is daily CBCT and for the CT. So for the simulation and daily CBCT, easy. Not even contrast. You should say no needles, no cuts, no nephrectomy, X-ray, and that's it. So it's general. We can reproduce. It's accessible, and is to be done. And something that do matter, it's counters, and because this is 100% related to safeness. This is a try. So we are doing efforts for having a standards, standardizing our procedures to have kind of a guideline about organ delineation, about constraints, and these are mostly being guided by the AROC group. But what we need to know quickly on our practice. So what matters is to start doing kidney saver. There's no more excuse if we have 4DCT and CBCT to don't offer this for our population, for our patients. And to be practical, it's important to make the different to counter differently the whole kidney, and also draw the kidney, just the cortex and the hilum, because the hilum we know that can hold more dose, and the kidney is a bit more sensitive, but the hilum it's we can be push a bit more dose there. Unlikely as percutaneous ablation, that's a huge limitation, the lesion being close to the hilum. And back ball, the big deal is back ball because of the constraints. So one thing that I always used to say and to do, it's when I'm gonna see a patient and I have to see to talk to him about dose and fractionation, open image and try to see if the lesion is close to bowel, and if it's close to the bowel, which bowel is that? Is this jejunum, ileum, or is colon? Because if it's colon likely in 5 fractions, the constraint is 52.5. So it's fine. So you know that, okay, for 1 fraction, it's 18 in 1 fraction. For no, for column, it's no, it's higher. It's 30, 32, it's fine. So if you see that, okay, it's close to the ball, but it's close to column, okay, one fraction, maximum three fractions, where when we are going to need more five fractions, for example. Five fractions mostly for lesions close to duodenum and jejunum. So, practical example, these are like the case that we dream, and the case that in some trials they when patients were selected, these were the case. So, posterior lesion is small, no way to have a bowel come here. There's no way of nothing can happen in this scenario. So that's the perfect case for one fraction of 26 or whatever. It's simple, and there's nothing to protect here aside the kidney. Here also, so uh, normal scenario. So lesion is not big. There's the duodenum here, but duodenum Dmax same of ball, but we have column also. So since we have, let me see if I can place a pointer. Oh no, pointer option, pen visible, laser pointer. Yes. So we're treating here. But since here is the column, so if we define the column, we have the arc will be able to play all here. So here the arc will play in almost 300 degrees. So probably in this case we would be able easily to treat with a single fraction, even close to duodenum, because of the column here. But if you draw here as a bowel, and we are going to limit the constraint, that's the same of duodenum, and then the arc will have just 180 degrees to play. So probably this case would be needed to fractionate probably to five fractions. So this is what really matters, organ at risk. So we define those fractionation always or much often because of bowel. So the deal is try to find the colon because it would be easy. Otherwise, if the ball is close to its real ball, like the June William, we are going to decrease to 40 grays in five fractions. That was the case. That was another example. So it's a big lesion, but here was close to colon. So here we prescribed 42 grays in three fractions, and we see that the max for colon is 45, and for back ball it's 30. So in this case, if you had drawn here as a ball bag, you shouldn't be able to deliver this dose. So as a column, 45, and here's the plan. So treating with 42 grays in three fractions, good plan. And we know that here we have more place even to play with columns, so it's fine. This some extreme case. So okay, big guy, and also there was like a thrombus here on the renal artery. And here, unfortunately, here was the jejunum. Here wasn't colon. Here is colon, but here jejunum. So 40 grays in five fraction, and 40 grays in five fraction is go smooth. Top local control, 100% comparable to one fraction and three fractions. There's some thinkness because of there was like on the data from the Rock publication of 2022, they found on univariable analysis that single fractions had better outcomes, but there's always the select bias, and the authors admitted that. So difficult case, in the doubt, 40 grays in 5 goes well. Constraints used to be fine, they are flexible, and we still deliver a ablative dose with BD more than 72 grays. This is very interesting. So this was so yeah. This I mean is the biological effect of radiation kidney. This is a subject that it's difficult to find on literature. So here at McGill, we did a study very interesting that we took eight health dogs, and so eight dogs, we got 16 kidneys, and we treated the kidneys of we treat these dogs with 30 grades in two fractions. Why 30 grades two fractions was not a study of those escalation compared fractionation, it was just to see the effect. And we couldn't do like in five, compare like three, four, five because of the timing. So we decided just because of that. But it's a kind of similar with 40 grays or 30 in five. And we did CT scan, all beautiful to the dogs, tarana, the organ at risks. And we did like this. We treat half of the kidney and one quarter of the kidney, the hilum and the pole, and then we starting killing the dogs to see the pathological response in the kidney, in the real kidney. So this was really nice. In 1 month, we saw that there was mild inflammation. In 3 months, there was edema, grade 2, inflammation, grade 2, 3, almost nothing fibrosis, almost no necrosis, and chronic inflammation a bit. Interesting. So we can think about many things here, about side effects, how long does it take in the kidney, and radiological response. So, okay, in 3 months until now, we saw edema. So what we are going to probably see on imaging if we ask in 3 months? Oh, it's growing. The radiologist, lesion is growing. Urologist calling you. Tumor board. Oh my God, biopsy. Salvage nephrectomy. In 6 months, was seen edema. This is top edema, chronic inflammation, and vascular necrosis. So here the kidneys, and look, I didn't put the planning because when we did the simulation, this, yeah, here is clear where we treated, the difference that we find, of course. And in 1 year, no more. So the normal kidney, the treat because there was no tumor. So the inflammation was came to grade 1. So this is the moment that we usually see the response when the lesion starts to show in the CT scans on the MRI on follow-up, finally starts to decrease inside, mostly because of reduction of inflammation. That it's a big factor that confound us. So this is tricky sometimes. Okay, so we have to remember that. So on the first patients when we start treating with kidney saber, okay, when you go to tumor board in 6 months, oh, the lesion is progressing. So in 3 months, the lesion was measuring 4.2, and then now it's measuring 4.5. Let's do biopsy. And we have trials showing that, oh, here was the CT scan. We have trials showing that biopsy doesn't show a positive lesion, a positive presence of malignancy there, it was just inflammation. And here I put in the wrong sequence, but was the simulations of the kidneys, and we can see here in the top where we treated, and the rest of the kidney was normal, and also here in the hilum, and we could see that in hilum we have a better resistance of kidney. So of course a small trial, this should be better studied, but it's very interesting in my opinion. Quickly, oh, 51 minutes I took already. Sorry, I'll try to be faster. Uh, this was a analysis just regarding renal function. So the publication of 2022 of rock, they did the evaluation comparing solitary kidney and bilateral kidney, because this used to be something that used to scare us. Oh my God, single kidney. The gentleman has 82 years old and renal function eGFR of 40, single kidney. No, I'm not gonna treat, da, da, da. But what's the other option? It's surgery or ablation. But we know that compared to ablation, we have similar decrease on eGFR. And we saw here on this analysis of 109 patients that the difference between solitary kidneys and bilateral kidneys was the same. So they had the same decrease on eGFR. And sometimes I hide here and to ask who among these two columns do you think that solitary kidney is A or B? And people used to say that is B, but it's A. So maybe even some improvement, but this wasn't statistically significantly. So uh, final, here I go a bit fast because of timing. So this it's very important. It's a kind of landmark to us because at least it's a prospective and random and phase two trial, but it's not randomized and it's a single arm. So the fast track was the publication from SIVA from 2024. That was the first trial, as I said, as a multicentric, was the first multicentric phase two trial for patients, and that's the thing. They selected well the patients in the prospective trial. So all patients with biopsy proven renal cell carcinoma, all inoperable or declined surgery, and this was really important. The patients with EGFR less than 30 were excluded, tumors less than 10 centimeters, and directed contact with bowel. And this, in real life, it's we have to interpret it well the data and the further data because direct contact with bowel it's something normal. It's the rule. The exception is when it's far from. And remember that dose was not randomized. So 26 in one for lesions less than 4, and 42 in three fractions for lesions up to 4 centimeters. And more than 10, they were excluded. And they found local control of 100%, so there was no failure in 1 year, and the distant metastasis survival was 12 in 12 months was 90% and 92 in 36 months. This is the just confirmed the data we already saw in the previous trial. So we always got this great result since first trials started with Saber, even the ones with low dose, like the first publication of Dr. Hanan that he used 30 6 grays in perfections, and even though he found around 97% of local control and a few distance failure, most because of the staging. We are dealing with T2 mostly, and this is very important. Here on fast track, they found a decrease in EGFR a bit higher of minus 10 mLs per minute, but a very nice data because they had a lot of criteria and many points that they measured EGFR, and they saw an stabilization, and this really matters. So okay, decrease of minus 10, but after in long term around in 3 years there was maintained in around decrease on EGFR around minus 14, minus 16. Regarding toxicities, low profile, but they had 10% of toxicities grade 3. Uh, okay, even with patients being excluded, patients with a bowel close to the lesion, they were excluded, and also the lesions were selectors do the size, and 10% of grade 3 toxicities, and 2 patients stopped treatment due to intratumoral bleeding or hemorrhage. But even though that's a great result, we're talking about up to 70% of patients having no side effects at all. And finishing quickly, we did just this comparison regarding our experience, how we do here, and compare with the data of the fast track, and we can have some insights regarding that because I presented this on our journal club last year, and I was just finishing the our 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 paper and our analysis, and I was analyzing the case, and I said, "Whoa!" About fractionation, because the one thing is reading. Okay, it's beautiful, 26 in one, but when you see the patients, it's when you see the old lady lesion close to the bowel, solitary kidney, or two kidneys, but close to bowel, it's too hard to think 26 in one. Oh my God, why I'm going to go for that. So but we should, by the way, we should. I'm not saying that we shouldn't. We should. It's my dream, and we're pushing for that now mostly. But so we treated 52 patients at McGill here. with medium size of the lesions of 4.5 centimeters. The pre-Saber eGFR was 56. 13% of patients had solitary kidney and with 30 months of follow-up. The data of fast track I already told. We most used 40 grades in 5 fractions. We used for 63 of patients. And when we see our planning sheet, our radon rack used to change it in 20%. So we are always aiming, we are in a third, one fourth of the patient. We are aiming 1 fraction or 3 fraction, and in the end we end up delivering 40 grays in 5 fractions because of the planning, because of the movement, uh, because patients real life it's different. It's a bowel. It's there's always something on planning. And in 27 of patients, we delivered 44 to 46 in 1 fractions. And on fast track, as I said, 33% they use it 26 in one, and in 67, 42 in 3 fractions. Remember that the deal was less than 4 centimeters, more than 4 centimeters. To us, was mostly the location, wasn't the size, and the size doesn't matter that much. Maybe for a prospective trial, but for real life, it's about organ at risk. So. We found also 100% local control. We had one failure after 39 months, and was like a case with a von Lippel-Hindau syndrome. And the patient had previous nephrectomy, was a solitary kidney. And he had, this was his, when we treated him, was his third primary, because previously he received nephrectomy, then previously he received in the kidney partial nephrectomy, then nephrectomy, then a new lesion in the kidney that we treated. But before that, he received ablation, and then he came to us. We treated with radiation, and then the local failure on him occurred 39 months later. But the lesion was close, wasn't the same place. So we still have doubts if it was like the a new prime or local failure. But even though in 3 years was there wasn't, but in 39 months we had our first local failure. Distant metastasis-free survival, 94%. The patient that had was a patient that we saw recently, 6 months later, no, 3 months ago. We treated his kidney, and then he came for a high-risk prostate cancer, and there was like a node, a bit upper to common iliac, and I was like pretty sure that was prostate cancer as a PET PSMA. Was negative, the PET PSMA, no, it was positive, but we asked biopsy and showed renal cell carcinoma. Was the first, the only, and this data is comparable to the series and to fast track, and cancer specific survival of 93%, which is amazing. And in my opinion, the most important, our find was a decrease in eGFR of -5 mL by minute, and followed by stabilization. And remember, and we had a lower baseline renal function. At fast track, they had a median eGFR up to 60, and they found -7 in 1 year, then -10, and then also stabilization. One patient on fast track required dialysis, even though there was no patient on the trial that, because of the exclusion criteria, one of them was eGFR less than 30. So even though one patient required dialysis, with it's one patient in 70. In our trial, we among our 62 patients, we no non-patient required dialysis. We had 2 patients that were previous on dialysis, but no patient required dialysis, and only 5% of patient increased the CKD level. So they went to 3 CKD, stage 3 to CKD 4, but no one required dialysis. And there was a interesting difference on toxicities profile. We had no grade 3, and we had only one case of a grade 2 that was chest wall pain. I previously reported one case of grade 3, but we followed this patient 1 month ago, and he was diagnosed with a thrombosis in aorta, no, in cava. And we were blaming radiation, so we changed that recently. And fast track, they had on fast track they had 10% of grade 3 toxicities, which is not bad at all. And we can see the safeness of kidney saver. And one important difference about constraints. Sorry about the time, but I will finalize now. But this is a very important thing. Is regarding constraints. Fast Track they used for one fraction the max of 26, and this is something that scares me at least. And we use the classic Timberman table. That's the max in small bowel, including the duodenum. It's the max of 16 grays. And in the patients that we treat at McGill, we don't push for we don't we never go over the constraints of team of the classic constraints because we are dealing with frail patients and we want to avoid maximum toxicities. So this is a big difference. So this changes at all. If okay, if you okay, I'm going to use the max of 26. You can largely use 26 in one fraction. Otherwise, you will need to fractionate and. I'll pass over because of timing. Something pretty important, finalizing. This is a very nice comparison that Dr. Hanna and Dr. Polsky, they studied this a lot, and it's about the timing of reducing the size of the lesion because this causes a lot of anxiety. And since it's a new technique, people start asking for biopsy, and we had one case that was very emblematic to us. Uh, After on tumor board, and the patient was very anxious. Urologist was much anxious than the patient was. Everyone very anxious. In 3 months, there was a increase on size, but on size, and like in the dogs we saw on our dog study, that of course in every site we have the swollen after 3 months from radiation. So in 3 months the image sometimes will be stable or with a big, slightly different size, and we can see in these studies that usually takes more than 1 year to start decreasing or stabilizing the lesion. So this is something that should be clear spoken with the patient. So, oh, we are going to treat this, and that. There's the chance of cure of renal failure. And remember, we are going to follow you with CT scans or MRI every 6 months. And usually, lesion used to decrease in size after 12 months. So, don't worry, it's about being the same page with the patient. And follow-up should be done with normally. And just remember, renal function always every 6 months. This now we have a guideline on kidney saver, top. So the publication of Siva and team, including Dr. Sagal, Dr. Slotman, from last year, and they recommend for lesions less than 5 centimeters, single fraction of 26. Otherwise, for larger than 4 centimeters, 42 in 3 fractions, 48. There's some doubts. And when those deviates are not achievable, 40 grays in 5 fractions, but with some regards. And routine biopsy post SBRT should not be performed. And we have, I didn't went deep on this point, but we had some trials. There's a very nice one of Dr. Hanan from 2023 that he treated, and he had pathology for all the case, and the most of biopsies were negative for renal cell carcinoma. And in conclusion, SABR is a non-invasive treatment that offers for patients with kidney cancers, RCC, a high local control rate, minimal toxicities, minimal severe toxicities, except a reduction in renal function around -5, -14, around 10% in a population that it's already likely to have this decrease, even in patients with single kidney. So don't hesitate on this scenario, and requires minimal technology. Likely, if you have for DCT and CBCT, it's good enough. It's be aware about the organs at risk, and try to find column because this used to happen to use a lot, to use single fraction or 3 fractions. That seems to be bad, and maybe this can on the future can show some benefit. And doxofractionation, it's fine. 26 in 1, 42 in 3. If difficult case, if you're in doubt, 40 grays in 5 fractions works well, works very well. Constraints used to meet easily and with same good response. I'll pass by that. And then to finalize, this slide is amazing. So it's about the new era that we are living on Saber. So comparing to nephrectomy, so we have like it's all benefits, you know, it's like the perfect deal, kidney saver. So compared to nephrectomy, okay, even they need general anesthesia. Okay, they can treat hyaline tumors, but not large tumors. Large tumors they will need require nephrectomy, and it's invasive. So comparing to percutaneous ablation, okay, they avoid general anesthesia, but there's the limitation regarding lesions in the hyaline, large tumors. The local control goes beyond 80% with lesions more than 4 centimeters, and is still an invasive treatment. And Saver, it's beautiful. Check, 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 check. No anesthesia. We can treat big, small tumors, whatever they are, and it's a no invasive treatment. So let's flow and this wave that we are going to benefit a lot, many patients with this beautiful treatment option that we have available now. Thanks for the time, and it will be a pleasure to answer any question. And if I know, or if I don't know, we are going to discuss here together.
Thank you so much, Dr. D'Souza. This was a really enlightening talk. Your commitment clearly came through and you really kept us engaged and energized. We do have some questions in the chat box that Dr. Ali has been addressing. I have the privilege to introduce Dr. Muhammad Ali, who is a radiation oncologist at the Peter McGill Cancer Center in Australia. Dr. Ali is internationally recognized for his work in SBRT in renal cell carcinoma. So his presence today is especially valuable for us. Dr. Ali, it's a real pleasure for us to have you here, and we would love to hear your insights.
Yeah, thank you, Maria, for your text and asking me to join. It was a really good talk, and definitely we have a lot of data over the last many years. So I think we
Ali,
can.
would it be possible for you to be a little closer to your mic?
Yeah, can you hear me now?
Yes.
Okay, yeah. So look at this time, like we know that for last 5 years, there is a significant influx of data. Like we have published IROC, which I was second author. Then we published Fast Track 2. Then we had single versus multifraction. Now the consensus guidelines, it's coming, it's on the way. It's currently under review at Red Journals. Hopefully it would be the consensus contouring guidelines for tumor and organ at risk. It would be hopefully, if Red Journal accept it, it would be within next 2 to 3 months. So the managing small kidney masses. So look, historically, always partial nephrectomy is the preferred treatment option. The reason being we have a long-term data. We know that it has associated with excellent long-term control, cancer-specific survival, and very minimal decline in renal function. Radical nephrectomy for tumor which are less than 7 centimeter, I personally think is a bit radical treatment, particularly irrespective of age. The reason being because removing a one kidney patient who had a one kidney cancer, they are always at risk of having a cancer in the other kidney. So for small tumor masses, 4-5 centimeter or even up to 7 centimeter T1 tumor, where the chances of metastatic spread is less than 10%, radical nephrectomy is a bit more radical treatment. So in those situations where partial nephrectomy is not possible due to technical issues or patient is medically inoperable, then comes the other 3 options. The first and always for small renal masses is active surveillance, like trying to delay the treatment. It's safe options for tumors which are less than 4 centimeter, because less than 4 centimeter, the risk of MET is almost 0. But as the tumor crosses 4 centimeter, with each centimeter, there is almost 5 to 10% risk of distant spread. So you can always, like in older patients who have multiple comorbids, limited life expectancy, even we can go for watchful waiting and give some palliative radiation if they started to have hematuria or they started to have pain. Any patient who is not a candidate for active surveillance or watchful waiting, then you'd have to go for the ablation. And ablation, like Thomas was saying, cryoablation or radio frequency, which is thermal ablation, different types of thermal ablation, and stereotactic ablative radiation. The reason, like Thomas highlighted, so we don't have any prospective clinical trial for thermal ablation to date. There are prospective cohort series or mostly retrospective data, but because it has few advantages. Number one, it's a good treatment for tumors which are less than 3 centimeter, and in certain situations up till 4 centimeter, you can treat with cryoablation as well. Advantage of thermal ablation over stereotactic, which to me is a very important one. The thermal ablation, the tumor is gone. You can see on the scans, you can see that there is no residual contrast enhancement, there is no mass, and there is just like a scar tissue. So in patients who are not a candidate for partial nephrectomy, medically inoperable, for tumors less than 3 centimeters, still thermal ablation should be considered as a better option because of long-term data, even retrospective, but we know that the control rates are high and the radiological changes are more certain compared to SAVOR. So where SAVOR comes into play, I personally think is mainly for T1B tumors, or 4 to 7 centimeter, up till 10 centimeter, we can treat it. And in patients who doesn't want, like due to some reasons where even the thermal ablation, which is an invasive procedure, patient is on anticoagulation and they can't hold the anticoagulation, or patient doesn't want, or in certain situations where the tumor is in the central structures, where like in the renal hilum, next to a main vessel, where due to heat sink, in fact, where the heat or like RFA, you can't give it good heat because of the continuous blood flow, heat is dissipated. So you don't get a temperature gradient to get the tumor kill. So in those situations where technically thermal ablation is difficult or more than 4 centimeter tumor, stereotactic ablative radiotherapy is a very, very good alternative treatment. So far, I don't think we should consider it as a replacement to partial nephrectomy. We need prospective data, and fast track 3 we are planning, hopefully it will be a multi-institutional. It's at early phases on development. Hopefully it would be a multi-national, like Fabio would be part of it. I think Fabio is the one who's treated McGill, if I'm not wrong.
Yeah, my mentor.
Yeah. So it would be interesting to see whether we would be able to pull up a trial comparing partial nephrectomy versus SAVOR. But at this time, SAVOR is the option, but it is an option for a very, very selective patients who are medically inoperable, larger tumor, and due to some reason, patient doesn't want other treatment options like partial nephrectomy or doesn't want thermal ablation, then you can offer it. And the major limitation is the response.
Yeah.
If you look at like we reported IROC, and we have sent like 5-year local control is around like 96, 97%. Similarly, fast track to 70 patients out of 70 patients, none of the patient had a local failure. But the limitation, if you go and look at the curves and look at the number of patients at risk, less than half of the patients make it to 5 years. Most of the patients, like in fast track 2, that was from Peter Shankar was the main author. So almost half of the patient died, almost 1/3 of the patient died during the follow-up. So it's actually like, if you can just hold it, just go back to fast track 1, fast track the IROC data.
I don't have a overall survival here. Just
Look over here, like you can see there at 36 months, you can see the
Yeah,
number
that's a-
41 and 29. So the
yeah,
41 or the 29 patient are censored. And at 4 year, 47 are censored. So it's
yeah,
basically 100%, but 100% for 23 patients. And Kaplan-Meier, as we know it, estimate the survival because there is no event. So it will give you like, okay, if the all the 70 patients make it to 4 year, it estimating 100%, but actually we don't know that. So you
yeah,
can call it 100% for 23 out of 70 patients. So that is the main limitation at this moment. Most of the patients who are coming for SAVOR are medically inoperable. One third of the patients die of other medical issues. If I look at, if I can give you our numbers at Peter Mac, we have treated 200 plus cases, and out of 200 plus cases, almost 40% of our patients died. So we don't, and the median follow up is around 4.5 years. But we have almost, like I would say, 10 to 20% of patients who we have followed up till 7, 8 years. So the long-term follow-up data is still missing. And all these curves are basically failure to local progression. And we don't know what is going to happen with those masses which are still there, whether they will still the same. We assume that it will stay the same, but still there are chances, there are tumor cells, even if a single tumor cell left behind, it can start growing. So that is one of the major limitations for worldwide utility of this one. And the other question about dose fractionation. So I think dose fractionation is mainly limited to institutional experience. Like at Peter Mac, our practice is one fraction and three fractions. We never do five fractions, even if it's GTVs abutting the small and large power loops. And but in real world, I would expect 1 to 2% of GI toxicity out of 200 plus cases which we have treated. I personally, like I think I have treated around 100 in last 5 years. So out of those, I can recall two patients. One had a grade 3 ulcer of the large colon, and one patient has a stricture and had to have a stent for it. So our toxicity, GI toxicity is around 1 to 2%, and it's mainly stricture or ulcer. And is there any dose response? We don't know that. And there are studies which have like gradually from 24 in 3 to 60 in 3. There was no local failure, and there was only one local failure, and you would be surprised it was in the 60
six.
and 3.
Amazing.
60 and 3.
Yeah.
So if you're starting a program, I personally always advise the best and safe treatment option is 35 to 40 grain 5 fractions. Start with 35 to 40 grain 5 fractions. And if you start feeling more comfortable, then you can go to 3 fractions. 1 fractions, if you're doing a lot, like if you are a high output center, and you know that your radiation therapist, physicist are really expert and you know what you're doing, you are treating that, then you can do a single fraction. But I personally think 5 fractions should be the way to start, and 3 fractions if you start feeling more comfortable. 1 fractions, we do it, and like I said, all our patients less than 5 centimeter, we treat with single fraction.
Thank you for that, Dr. Ali. It's a big pleasure to have you here. Big pleasure at all. I'm a great friend, by the way, and thanks for that. And uh, in like cases like this, would you go like this, for example? You go for single fraction easily.
Yeah, easily a single fraction.
And
And
and the dose to duodenum. It is because I asked it to Siva in Warsaw last year. I said, when you see the plan evaluation and you see there the max on duodenum, not even 26, but the max 22. Like, are you fine? Like, are you like chill, or you say yes, but how do you feel on that?
Well, look, I think the important thing is the most important thing is like we all have, I know we have a constraints. The plan is going to, the physicists are going to achieve that. No way, like we are not going to approve any plan where we are going out of the tolerance. The most important thing in deciding your fractionation is whether you are going to deliver the same onto the patient. That's where the things get better. So what we have adopted it, and that is based on our fast track 1 experience. So if you look at fast track 2, so there was a 3 millimeter PRV. So this the constraint which you showed 0.03 cc 26 gray. So that 26 gray is actually to PRV, and that is 3 millimeter. And if we
Mm.
look at the actual true structure, it would be around 2021. Similarly, for the large bowel loops where V26 is 1.5, so that is actually to PRV, 3 millimeter PRV. So the actual structure would be around 21, 22 gray. So we are getting a cushion, and adding the PRV, what it gives us the advantage, like it gives you extra 3 millimeter of cushion, and due to some reason, you can't, like cone beam CT has a significant artifact because of the gas, or there is some error, so still you're feeling safe. So we compromise coverage a bit, like in situations like 4 centimeter tumor abutting the duodenum or abutting the large colon, large bowel. So we compromise the PTV coverage a bit, like rather than accepting 95 or 100%, we drop it down to 70 to 80% so that we can meet the constraint of it. So we don't depend on a proximity to the OARs to decide whether we will go with single or three fractions. Our is a size cutoff anywhere where we are size, and all the single kidney we tend to treat with one fraction. And the reason being, I personally believe because of a higher alpha beta ratio for kidney function, we don't have any data to support that. So for me, I personally believe the total number of like total dose matters rather than the fraction for when we are going for loss of GFR. So if I'm giving 42 in 3, so the 50% isodose, 50% dose is 2022 gray, which will lose more function. And if I'm treating with 26, so the 50% is 13 gray. So I'm avoiding most of the kidney from 15 to 20 gray mark. So most of single kidney, I personally, even up till 5 centimeter, I go with single fraction. And the reason being is to preserve better renal function.
Yeah, this is
And
something so nice. Sorry, but when you have like the experience like you have, I was reading one of the trials that you published there and in your team regarding the comparison on the dosimetry and also with the kidney nuclear study comparing dose and fractionation. And on the report, I think from 2014 at Peter McCallum, you showed that there was no difference between and using the scintilla of the kidney, and and this is the kind of thing that you are just able to do when you have the expertise and the data, and you did many your group has a huge background of trial support in your practice. So I think this makes all the difference. And
like I said, it's more about your acceptance and your trust on your team. Like before, we were doing all the match by RO, like me, Shankar, or other ROs. We used to go to the machine and do the cone beam CT and do matching. But now for last 2 years, our radiation therapists are doing it. They call us only if there are any issues. So it's more about building a good team that makes life easy for you. And all of our cases we discuss, like if Shankar is doing kidney saver for last since 2012. So he started fast track 1 in 2012. So for last 13 years, he's doing kidney saver, but all of his cases are reviewed in chart round as well. So we go through all the volumes, we go through all the physics for the CTQA, we go through all the dosimetry. So it's a like a quite vigorous kind of quality assurance program to make sure that we can deliver what we want.
This is amazing. This is amazing. And reported, yeah, the publication of the quality assurance of your department, it's huge. It's huge. And congratulations.
Thank you very much, Thomas. And there is one question by Iram, which patients with less than 4 centimeter were not candidate for active surveillance? So look, there are a few things. Um, the most important predictor is tumor growth, like any tumor which is growing 5 to 6 millimeter a year. It gives you a risk of spread and a risk of losing that window of opportunity for cure. So tumors which are growing fast, less than 3 millimeter per year is considered a quite safe option. Any tumor which is 3 to 6, it depends on patient anxiety. But if it's growing more than 6 millimeter per year, it's better to treat early. Because look at, if say you have a tumor which is 3 centimeter and it's growing 6, 7 millimeter a year, so within a year you are going to treat it. So you are not giving a, but if a tumor which is growing 1 or 2 millimeter, and even if it's a 3 millimeter, 3 centimeter tumor, so you can safely avoid treatment for 5, 6 years. And another thing is, we don't have a lot of data, but what we can see is the aggressive tumors. Always, if you want to put the patient on active surveillance, try to get the biopsy if it can be easily done. And tumors with the grade 3, 4, like clear cell carcinoma, grade 3, 4, or sarcomatite component, or any rare histology, which are aggressive tumors, then better to treat even at smalls. And single kidney, I personally treat it early. The reason being because they have single kidney at small size, you will preserve more. Large size, you will lose more kidney.
Completely agree. And Dr. Ali, something that spoke, I stopped the presentation, but quickly here. Because of, yeah, I completely agree that our big challenge is about follow-up and ablation, percutaneous ablation. You went, perfectly. The advantage of them is response, and then raw and the patients, rods, we get used on seeing the lesion decreasing in all other sites, and but on kidney saver, and this is something that we say that's fine, sometimes on tumor board, no, like lesion increasing, and it's good. Let's do one more, but I'm always afraid. I'm always afraid of being missing some progression, and we just developed this predictor model here, and we're going to present now on Astro.
Mhm.
We did an analysis show taking all the images, like counting voxels and using like a deep neural convolution, and it's mostly to see the chance of reduction in size, like predicting the chance of size reduction in over a year. So that was like was kind of to answer tumor board in our doubts. So what if we could identify which patients would have a better or faster response to Saber, even before the treatment, just by the features on the follow-up imaging. And we use like driving using like phenotype, and also we used pathology. So we put all these slice, and we did the convolution, neural convolution with pathology and image features. We used 3,200 some image features, but in the end, only 19 were positive and were significantly showed a difference. I didn't put the data here, but our model was able to predict with accuracy of 88%, and dividing, and we have a p of less than 0.001, showing the patients likely to be late or early responder. So we are just excited to present and maybe to try in a bigger database like yours.
Yeah, so look, at the moment, like like we measure all the based on RECIST, which is based on one dimension, maximum dimension. So if we look at even like I can give you, like you can see another Beth Israel, which is Anand Swaminath. He's from Canada as well, I think, isn't it?
Who?
So Dr. Swaminath, Anand Swaminath. So what they did,
Yeah, Toronto. Yeah, Toronto. Toronto. Yes.
yeah, so they published their 23-24 patient data earlier this year in Red Journal, and they have shown that volumetric changes are more pronounced compared to single dimension. So like here, we know like most of the kidney tumors are like elliptical structure. So they have like craniocaudal, supine, and post direction. And most of the time they shrink in all the directions. So you have more volume changes compared to maximum dimension.
Hmm.
And
Hmm.
our data, which we are going to, you will see in coming few months in some journal, we don't know where it will go, but it will somewhere go.
You just
So
go to
what we
Lance.
have, what we have seen is like our median follow-up is around 4.5 years, and we have seen like almost 60 to 70% of the patients, they have more than 30% reduction in volume. And if we look at maximum dimension, it is only 15 to 20%. So the volume
How long
reduction
time?
is, and it's more in the long run. And that's what I'm planning as well, to do some radiomics and see if we can predict the patients who have a response. And rather than doing 6 monthly scans, just don't do the scans and just do ultrasound or maybe even no imaging. But the limitation of all these models are because we don't have a lot of what you call
Failures. You don't
failures.
have event.
So we will not be able to give a good call at all. So at least for next 10 to 15 years, we will not have any answer. And that would be the biggest criticism. Another thing which can be like we are doing based on fast track to looking at MR, multiparametric MR, and seeing whether we can predict the response. And another thing which could be interesting is CAIX, like brentuximab, carbonic anhydrase tracer, and looking at like how it can change over time, particularly in clear cell carcinoma. So response is a big issue, and I think that would be the limitation. I personally try to avoid treating anyone who is a younger patient, and that is the reason being only limitation of response. If they can have any other treatment, I always push for that. If they can't, then definitely SAVOR. But response is biggest worry for all of us, unfortunately.
All right.
There was one question I can just answer before we can just finish it because it's already quite long time. Iram asked about limitation of normal renal cortex. So like me and Thomas was discussing, so based on Fast Track 1, which was published in 2014, and last year Fast Track 2 data was published as well. Even like last year, or no, start of this year, Fast Track 2 data was published as well. And that have shown that try to minimize 50% isodose line. So the loss of renal function correspond to 50% isodose line. So if you're treating two functional kidneys, one kidney like left contralateral kidney, in our case, contralateral kidney never had any dose. It's always mean dose is less than 30-40 centigrade, not more than. And the same kidney, ipsilateral kidney, try to minimize 50% isodose line into the normal renal parenchyma. But if you're treating single kidney, we try that V10 gray, volume getting 10 gray should be around 30 to 35%. And in certain situations, we can accept up till 40% as well. And while doing the renal cortex, like renal cortex on its own is a very thin 1 to 2 centimeter layer, but in order to make it a much easier for ourselves, we just exclude the renal hilum and rest of the kidney we what you call make it as a renal cortex. So there is no consensus renal cortex constraint. But for single kidney, remember V10 grade 30 to 35%. And when you're treating with the patients with two normal kidney, minimize 50% isodose into the normal renal parenchyma.
Yeah, used to
All
ask
right.
here, next of a kidney avoid less than 70. Yeah, it's kind of same. Trying to find a way.
All right. Thank you, everyone. It was a very engaging discussion today. Um, it was like very passionate from our speaker, and I would also like to thank our esteemed expert, Dr. Muhammad Ali, for adding such depth to the conversation, and especially the clarity that we received from the questions that were being discussed during the Q&A session. It really added value to today's discussion. So it was a real privilege to listen to our speaker and our expert. That's all from us today. Thank you, everyone. Bye bye.
Thank you very much.
Thank
Thank you for
you.
all. Thank you for
Thank you,
President
Robert.
Dr. Ali. It was a pleasure to hear from you.
Thank you. See you
Grandmaster.
around. Thank you.
Thank you.
Thank you.
Bye.